Thank you, Shimul, for the nice introduction. It's very nice to be back after here 6 years and to see the development of this association, and now that's called the Americas, and I'm very delighted to see the success and the number of people and the quality of the presentation here. So I will try, which would be difficult, to match the quality that I have seen until today. So what I will try to do in the next 45 or a bit less, because I think it may be good to have a discussion at the end, is to speak about this ALPPS procedure and to ask the question whether this ALPPS is part of the past, is the present, or whether or not we have a future and what for a future. So first, I think we need to see what we talk about. We talk about extensive disease in the liver, which are primarily not resectable. And clearly, when we go into this, we know already in advance, when we go to innovation in this area, that there is some inflammation and discussion. And then it became well known that 2 years ago, someone here did a presentation about the ALPPS, I think in this audience at a very early stage. And I say he showed this slide because he was here when I was today, and everybody was looking at him like a, I don't know how to qualify, like a criminal. This was this man, and he's in the room here. And 2 years later, I think many things have been documented in this disease, in this operation, and I hope I will be able to convince you about where we are today. So I would start to remind a bit what is the ALPPS, the development of ALPPS, where we come from. Then we need to compare what exists, and I will show two things. One study that we did with 4 centers to compare that to previous strategies. The study from MD Anderson, which was published. We have now the registry, and I'm very pleased to present for the first time the result of this registry. We designed a randomized trial, and at the end, we like also to understand a bit better what we are doing, and I may show you some results in the laboratory. So first, let's go back and what we are doing since 10 years with some variation, which is the 2-stage procedure. When we have a first stage, you can see either we will do portal vein embolization, or we have to operate this patient, usually because we have to remove also some tumors on the other side of the liver, and we ligate the portal vein. Then we will wait here. We have to wait 4, 8 weeks, sometime more, until we get the volume we want to have. Could be 30%, that's still open for discussion, where we think it is safe, relatively safe to go back, and then we go to the stage 2. I call that the classical or the operation that is still done by many today, and we have some data on this operation. An example, here you have this patient with multiple colorectal metastases were paid by us, and here you can see here 6 weeks later, you can see the right portal vein is gone, the right hemiliver is small, the other one is bigger. What we see on segment 3 is a wedge resection, and here we can go, we do surgery in this patient, we do the wedge resection, we ligate the right portal vein, and then we can, that's a stage 1, and then we go to stage 2, and this is somewhat a classical operation that has been done in a number of patients. So what's the problem with this strategy? Well, there is an obvious problem, is that only 60 to 80% of the patients you take in the opt-in group for stage 1 will have stage 2. That means they will benefit probably from nothing or even have injury. So, in other words, 20 to 30%, because the liver doesn't grow, because the tumor is too big afterward, will never aid a second operation with this strategy. So that's when came this small series in 2012, presented a year before at the EHPBA meeting in Cape Town, multicentric study from Germany with this new operation that I will describe, and with Eduardo de Sambinanias, we wrote an editorial. We had some experience at this time, not much, but a little bit experience with these procedures, and we decided to give an acronym. We thought this will be an important procedure. We were optimistic. We predict that there would be a lot of discussion, so we were working on a simple name for this. Maybe it was a little bit biased, but we call that the ALPPS operation for associating liver partition and portal vein ligation for stage hepatectomy, and this terminology has been adopted by many today. So what is this ALPPS? So here we go back to the same operation as before, with one difference, is that with the portal vein ligation, we will do an in situ split. We just split the liver as we do for living donation. And we can, if necessary, do also the tumorectomy on the other side. Now that's what is new here. We will wait 1 week, and then in 1 week we observed, and that's what these people in Germany observed, that was the first credit, an absolutely fantastic or phenomenal or at least surprising regeneration in a very short period of time, and then they could complete and go to stage 2. So basically they repeat this what we knew before, but in a very accelerated manner, 1 week. Now, I will show you here some example. I'll go, and that's the first case we did in Zurich, very atypical case, young woman with metastatic hemangiopericytoma. She had a brain tumor operated about 10 years ago, and she came with these pictures, and you can see multiple liver metastases, and we want to help this patient. Not sure how we can help this patient, and we decided here to go for the first ALPPS procedure in our center. We can see here that the future remnant liver, basically segment 2 and 3, was only 19%. So we went and did here the in situ split. You can see here, and the radiologists were very worried when they saw this picture for the first time, because they see this liver splitted, and that was very something they've never seen before. Here you can see that was 7 days after that, pretty dramatic increase of 90% from this small remnant liver, and then we could go to the second stage in a very rapid way, day 7, and here you can see a dramatic increase even after we removed the disease, the liver here, of 170%. So with this first case, patient did very well. We were very excited, and we decided to continue to do that. I'll show you another example here. That was a small series that we published with other group. I show you here a patient, also a young patient, obese, who failed a portal vein embolization, portal vein ligation here. So he had a portal vein ligation with the idea, was metastatic colorectal tumor, to proceed with the conventional therapy. Unfortunately, it failed, and it was 22%, so we decided here to go for an ALPPS, postulating that the ALPPS is better than portal vein embolization and can rescue this situation. In this case, we were right. You can see here again the typical picture after an ALPPS. So you see the in situ split, the tumor on the other side, and here we have an increase to 47% again within 1 week here, which is about, again, 80% of increase, and after a week after, we do that in all our patients, we restage this patient, and here we can see a dramatic increase again, the same, about 170, 180% in this situation. So in this small series, we could show that ALPPS can rescue failed portal vein embolization or portal vein ligation. Picture here of one of these ALPPS. You see here the hanging maneuver. This is a split, as we will do for living donor, as I say, and at the end we will ligate the portal vein here, just a small drawing of how it goes, and then the idea, 1 week, no adhesion, we can go back, and with a stapler, what's left is only the hepatic artery, the right portal vein in most of the case, and here with stapler and ligature we could complete a relatively easy second stage. Those who have done the conventional procedure and go after 2 months know what challenge it is to take out the right liver 2 months after a major surgery with all the adhesions that there is after this long period of time. Well, that's it, and I want to quote here Marguerite de Yourcenar, who was the first woman of the Académie Française, not the search for surgery, but for literature, and she said, any truths create a scandal, and this, I think, create a scandal and a lot of discussion. And then after the publication in the Annals of Surgery, there was many letters written by very prominent and respected surgeons in the field. And I will quote here from my friend Nicolas Vote here, who wrote a letter to say, well, 12% mortality, this is not acceptable, morbidity is too high, we are going back to the past in liver surgery. And then we are losing the oncological selection. You operate so quick that we don't know what the disease is about. And in addition, we're happy to discover that the liver doesn't grow in some cases, because that's where we have problem in the future. And even postulate that this huge regeneration, that means a lot of growth factor, inflammation, and that will boost the tumor, and probably this patient, from an oncologic perspective, will not benefit at all from this. Another letter here from a prominent French surgeon, Jacques Belghiti here, who did, in fact, 8 of this ALPPS procedure. In half of them, he ligated the bile duct, he decided, and he had a number of bile leak to that. And he observed, which is correct, that volume is not a function, and that's one of the topics today. And he suggested by the technique that we may violate the non-touch technique for cholangiocarcinoma, for example. In our experience, in fact, it was the opposite, and we were far from this, but that was the criticism from Jacques Belghiti. Now, at that time, what are the potential benefits? Well, the potential number one is to attack very small remnant liver with this ability to regenerate. Clearly, we thought we have more chance here to achieve R0 resection, and we all know that the only way we can cure this patient is R0 resection. Anything less than that would not be very useful. The time, short time, will prevent the progression of the disease. So we have the opposite feeling that was suggested by others. The adhesion, I mentioned that, easier surgery, patient is only one stay in the hospital, so some of these patients have this diffuse disease and 2 weeks later they go home. It's not always the case, but that can happen. And it may also be that the partition may prevent, that's also in theory, the dissemination from one tumor to the other one. There is a partition, the tumor cannot grow in the other side, and that was demonstrated that we rescue failed portal vein embolization or portal vein ligation. Now, there was a number of publications after that, so we have a short period of time. We speak about 3 years, and this is increasing. Many letters in the Annals of Surgery, for example, came, and mostly these people now speak about success. They've done a few cases, it works very well, and there is basically no, or was no, comparative study. When we have a new procedures, we have to ask the question, is that better than what we are doing before, and how can we answer these questions? So for that purpose, we designed a study. We went back to our database and wanted to compare the conventional approach that I mentioned before, including portal vein embolization, with the new ALPPS in a few centers who have some experience with this procedure. It was a retrospective analysis. We even did a sample size analysis. And the primary endpoint, we cannot have long-term, we have to do it early on in this, so we decided to look at the ability of the procedure to have a R0 resection, again knowing that this is the best chance for this patient to have long-term outcome, but in that study we did not have long-term outcome. So there was 4 centers involved in that. We started with 170 patients. Screening those patients, we end up to 131 patients. 83 of those had either portal vein embolization or ligation, and 48, which was a large number here, decided to have ALPPS. So what did we learn of that? That's the number of patients and centers that were involved and enrolled in this study. Number one, we use that for different indication, but most of us we use that for colorectal liver metastasis, but you can see there was another number of indication here. When we compare that, there was basically no difference between the two groups. The number of lesions was a bit higher in the ALPPS, but basically these two groups were, with the bias you can have in a retrospective analysis, comparable with quite small future remnant liver. And that's the result here. So we could show with this first study that ALPPS have indeed a higher ability to offer R0 resection to this patient, 83% versus 66%. If we calculate the odd ratio, it's not negligible, about 3.3 times. So this was the first suggestion, by adjusting also for age, etc., that the ALPPS might well be better than what we have done before. And then came, of course, the question of safety. In this retrospective analysis, we had a 6% mortality in the portal vein embolization ligation. It's not 0. 15% in the ALPPS. Now, importantly, who did not reach the stage 2, that means they have surgery, a procedure for nothing, 25%, while none in the ALPPS could not benefit, or at least from the stage 2, and the incomplete rejection was relatively low in both. Now, if we just look at timing, because that's a major aspect of this procedure, you can see, I don't need to comment here, that the ALPPS in terms of timing is totally different. And we calculate for each patient the regeneration. We were fascinated by this regeneration, and here on the left side you have the ALPPS, the portal vein, the other side for each patient, and you can see that the curve doesn't look like, and when we calculate that, in fact the speed of growth per day was about 35 cc in the ALPPS and 2.8 in the portal vein. So clearly from this suggestion there's a major difference in this new procedure to trigger liver regeneration on the other side. Now, we show yesterday also a poster here, and that's one of the topic, is that volume is one thing. Well, I think we have to look at that, but we like also function here. And here we have shown the HIDA uptake by the liver that was developed, this procedure by the group from Amsterdam, von Gulick and others. And it's a simple formula, but basically you look at the uptake of what you want to keep, the future remnant liver, over the total liver uptake of the liver. They did a ROC curve, sensitivity specificity, to come here with this number, which will be the safe number of uptake in the liver. So we look at our data based on that, and here this is a mixture of ALPPS and other procedures where we have this data, so that part of fact of the randomized trial that we are running here. And very interestingly, all in green are the patients who are above this cutoff and did well, and we have 2 patients who were not, who in fact died from surgery, and you can see one of these, he had a good volume of 0.40, about that, but the HIDA scan was poor, and this patient did poorly. Is that the definite answer? I don't know, but this is one way, I think, to assess that. Here, this is a slide from Buenos Aires for the group Eduardo. When they are doing the same, is an extreme case, when they preserve only one segment. You can see the pre-op CT, the post-op CT after stage 1, and also you recognize the in situ split in the middle of this liver, dramatic increase. And here they could calculate also by the HIDA scan, here they calculate, like we calculate for volume, the percent for the versus the other part, and they have 26%, and decided in this patient to proceed with surgery in a safe way. I move to the next, because of that we are basically only the believers. That's the people who want to promote in the first stage of an operation. We have done this operation. We are not saying it's good for everyone, but we see a future for that. So what is, when we look at the people who wrote letters and thought there was no major interest for this procedure, and I would like to go through here with the work from MD Anderson by Tom Aloya and Nick Vote, who wrote a paper published recently in the Journal of the American College of Surgeons. So what they did in comparison, they took the initial group, the 25 patients from Germany, the first time it was done with this 14% mortality, and they look at the series, and we know they are very well known for portal vein embolization. No doubt that this group is a leader in this field. They take all patients from a relatively long period, then they take only the portal vein embolization. We include the segment 4, which the one was the best ability to trigger regeneration on the other side, and then they limit to those who had a relatively small remnant liver, and end up with 144 patients. So here we have 25 patients for a novel therapy done by people that they've not done before, versus portal vein embolization from a group who has large experience. So to start, I mean, when you review this paper, you have to doubt that this is a fair analysis, but let's go through this analysis, what was coming from that. So if you look at the MD Anderson here, you can see they have a 6% mortality. In fact, it matches exactly what we had in our 4-center study, the morbidity, complication which require here reoperation in this. And if we look at the ALPPS inaugural study, again, 24 patients here, there was no significant difference. Of course, statistic is difficult. There was 2 cases of bile leak and sepsis, so there was a few things indeed that the ALPPS procedure, they occur in the less frequently in their series. Now, let's go to this series of 144 patients from these expert centers. We have 144, great. Now, failure. There has been some of these patients, they did not have portal vein embolization. It did not work when they did it. They have complication for portal vein embolization. We all know we can have that. And then at the end, they also remove some patients because regeneration does not occur. And they have other complications when it was successful, including they decide at the end regeneration was not good in one case, and they have medical comorbidities, etc. So at the end of the day, from these 144, only 104 were able to get the 2-stage, so to have the real procedures. What that means? Well, look at the data. The 104 and the 40, the one who gets the entire procedures, the 104 versus the one who did not, there's a very dramatic difference in survival, and I think we can question what we offer to the patient when we don't go for the second stage. So about a third, 30%, did not, went to the complete resection. And I just want to read here the conclusion from this study, based on its ability to select oncologically resectable patients and superior safety and efficacy, portal vein remained the standard of care for patients with very low remnant volume liver. Well, here I'm asking, looking at this paper, even if the conclusion is justified. I don't know if Nick Vote is in the room. Maybe, I hope he is, and that's, I'm asking here, who did that recently, whether I can drive him to this paper and see whether he can also critically look at that. And in addition, portal vein embolization is not an option if you have tumor on both sides. I move to the next evidence. So when we started that, we realized we need to collect data, and we opened also together with the group from Buenos Aires and also from Germany, from Auke Lang, we decided to open an international registry, contact many people, and did everything we could to have patients in. And this is, as I mentioned before, the first time we are presenting this data here. So in December 2013, in a short period of time, we had about 250 patients in this registry from 56 centers. So I think this is a big success, and just show the compliance of many HPB surgeons, because entering patient in this database takes 35 minutes. It takes some time in order that we have the data. So we decided to do the first analysis here, and we got 202 patients where we have a follow-up, complete follow-up of at least 3 months. And we have 41 centers for that. And the first question, because everybody's asking about that, what's the mortality, what's the morbidity, and what are the risk factors associated with these procedures? So that's the result of this. You can see that 70%, so the majority in this registry, were done for colorectal liver metastasis, but not only here, also many other cases, and you can see even advanced cases like gallbladder cancer. And my center, we have done some of these cases, sometimes with not big success too. Now, if we look at the registry here, the age is about the same. You can see that most patients had chemotherapy before, and that in many patients, more than half, the parenchyma of the liver was not normal due to chemotherapy or steatosis. Here is the time. I show you 7 days, the registry. I guess people were more careful, or maybe they're right. The average time between the first and the second operation was 10 days, but you can see it was never above 15 days in this registry. And here is the result, and that's confirmed the initial suggestion for the study. 98% of the patients, basically everyone, reached stage 2. The mortality was 10%, 9%, so it's still significant, can be ignored, and the complication, we call serious complication, was about 26%. When we look at risk factors here, you can see we found what we always found basically when we do major liver surgery. Blood transfusion is not a good thing. The duration of the operation of the first stage play a role. It may mean many things, it's difficult, etc., but it was a significant factor. The age also appeared to be a significant factor here, cut off at 60, and the colorectal liver tumor did better than any of the other indications. And if we go to the types of tumors here, you can see here, if you go Pierre-Alain cholangiocarcinoma, this is again complication more than 3B, including deaths. We can see go to 60%, very high for some indication, and 21%, I would say, only for colorectal liver metastasis in this series. And if we even restrict to the patient less than 60, then this complication go down to 16% in this group, with a mortality of 5%. And here I will say also only 5% with this extensive disease. Now here, if we go to the survival, we have data up to 2 years in some of these patients, so we can, for the first time, do a survival analysis limited to 2 years, and we can see that is this patient with colorectal liver metastasis, the 2-year survival is 75%, so that's not bad. Now, can we compare that with what's done by others? So again, here we have to go to data, a little bit speculative, and we went here again to the very active group from MD Anderson. We published this series in JCO here, and that was their data looking at long-term survival after 2-stage procedure here. See, the median age is about the same, a bit younger than what we have indeed, the tumor size. And if we compare to the registry here, they basically no difference between these two groups. means of chemo also the same. So basically the same population. So we can compare, maybe in a fair way, these two groups. So here's the data that we have, and you can see that that's the result from the advanced bilateral color, the two-stage strategy, that the survival they have. I put at 24 months this blue bar on the left side, since this is the data we have in the registry, we see later. And you can show also if they have only chemotherapy, the results are very poor. No surprise, I think we know that. If we look at our registry here, and you can see here that basically the registry with the ALPPS procedures is the same, or looks the same, that the study in the MD Anderson group. Now again, we have to look here at the angle, because we look at the patient after surgery, or do we look at all patients who are candidates for this two-stage procedure? And here comes clearly a difference, and you can see here in the group from this MD Anderson, the 47 who got the second stage, indeed had a 70% good survival, but those who do not, in my right part, they did very poorly, and this is quite significant. This is about 30% of the patient, while I remind that in the registry, basically every patient reached the second stage. So I'm asking here to the group whether this 30% that we are losing, is that really a selection, or is that just a failure of treatment? Now, if we look at a few slides, and I borrowed that to Eduardo, who will present and discuss that also in Seoul at the ALPPS meeting here, and I will go quickly through these different data, and basically is to compare with what is available in the literature, and I come again to the resectability after the second stage, and consistently there is no paper that match what we have matched with the ALPPS registry, and we go here to safety, another issue here. If we limit to colorectal liver metastasis, if we speak the same language here, you can see comparing this publication from other center, and you can see the name of this center are experts in liver surgery. We are comparing here in a very fair way, basically the best center that exists. Here, the ALPPS registry seems to match perfectly the mortality that is associated with the two-stage procedures. And if we look at survival, because at the end of the day, that's what we want, quality of life, we don't have data here, and survival here, and it may well be that ALPPS is better. And I put in red the JCO paper from MD Anderson, and we have 59% one-year survival versus 39. We don't have data at 2 years for the other group. We have 41%, 20%, and I think it would be very interesting to look at the long-term outcome about this procedure, which is, of course, not available at this time. So based on this data, there was some question, I think it's absolutely clear. We have to do a randomized control trial now. If we don't, the procedure is so successful that we may never do it, and we may not offer this patient and this procedure to the patient we want. And I will, and here, the registry, I will show you the randomized later. The registry here has enabled to anybody to want to come with some special innovation here. The monosegment, septisegment, etc. I will not go for time reason, go to that, but this is a vehicle, a good one for people to give their innovation here. Here, this is another paper from Argentina here, where they did the entire ALPPS procedure laparoscopically, was done also by the group from Brice-Gaillet in France, and a few others. And here, this is another one which was proposed by a group in Spain, when they said they do not transect, they just ligate that in a few patients. Whether it's the solution or not, we don't know, but at least it's communicated what can be done. Now, I will recommend that everyone, and I talked yesterday, go in the registry who does that. And particularly if you have a problem, the registry is not here to show the good data only, is to go as close as possible to the truth. So we have talked, because there's not so many people, even we know each other, and we've been very active. For example, Jacques Belghiti, we had some problem, accepted, and he put his cases in the database, and I think this is very important. So now the future is clearly a randomized control trial that we have initiated here with a few centers that are listed here. We will go here also for R0 resection at 6 months as the primary endpoint, look at other important parameters. Sample size suggests that we should have 80 patients to look at this, to compare with the standard procedure. 7 patients were enrolled, and based on the analysis that we did, we will decide, we change that to go only on colorectal liver metastasis. maybe to be safer, but also to be able to interpret this data in the long-term survival. And we will also use some way to analyze the function and not just the volume by FDI scan. Well, I want to finish here by speaking about mechanism. As a surgeon and doing this, it's great, it's exciting. We can help some patients that we thought we could not help. It's a great satisfaction from that. But we want to understand this, and then we went to the lab and see whether we can learn in the lab a little bit more about this procedure. And another question, is that true that this in situ split do something? So here, Dr. Andreas Schlegel, who is working in my laboratory and would have this work presented at the European Surgical, developed a model in mouse, and you can see in mouse you have here the left lateral segments, and here we ligate all portal vein except the portal vein going to left lateral segment. She proceeds with an in situ split. You have the black the dot here as a stage 1, and then 2 days, so in mice the liver anyway grow faster, and at 2 days we try to observe whether there is regeneration or not from this part of the liver. So here's the first data from this. You can see here, this is the percentage of volume increase from this part of the liver over time, and you can see that the ALPPS versus portal vein ligation alone versus transection alone versus control, the other one, we have to remove a very small segment in order to do this operation. Clearly the ALPPS has a better regeneration than the other part here, and if you see at day 1, which is very good, you have 100% more liver growth with the ALPPS than any other part. We also document that with marker of regeneration. It's not just volume, but all the mitotic marker were about twice higher in the ALPPS than it was in the other one. Okay, now what are the underlying mechanisms? How this can happen? I don't think we have the definitive answer, but some suggestion. This is this model. You can see the in situ split that is done with cautery in these mice. And here what we decided to test is whether it is circulating factors or whether there is something that prevents the blood going with one part to the other part of the liver. So here we designed the same model, but we did not do the transection. So we do portal vein ligation, and we do section of other organs, so kidney, spleen, and lungs, and see whether we can achieve the same degree of regeneration. And here's the result we can see here, and you can see the ALPPS in blue is very close to any of the portal vein ligation without transection of the liver, but transection from another organ. Portal vein ligation is less, and the other control group are much less. So in order to see that from another angle, we did another experiment. We took, again, the mice with only portal vein ligation and inject the plasma from the mice who got the ALPPS. So we take the ALPPS, we take the blood and inject in a mice who has only portal vein ligation, trying to test whether we can transmit something that will increase growth of the liver. And it did, and you can see here the ALPPS in blue again. When we inject portal vein with the plasma, we have an increase in size, while portal vein and any other things is less than this degree of regeneration. And we concluded that in fact what's happening, maybe not the only factor, but it's probably one, that by doing so we have the release of growth factor inflammation, to be identified was exudative. It's probably a combination of them, which caused this accelerated liver regeneration in ALPPS, certainly in mice, and probably in human. And this will show you the last case here that come from this experiment doing in the lab. We have even attacked some very difficult case and have done some partial ALPPS, suggesting that it may be in some cases safer and probably as effective. So I just show you here this young patient, or young 60-year-old female, but at least in the cutoff for that, we had colorectal liver metastasis, and she had a resection of the primary tumor some time ago, and she presented with this disease. And I can tell you that many centers would not even talk to a surgeon. So that was this extensive disease, and we did what I think anybody will do in this case. She received some chemotherapy with this disease, and you can see there was a nice answer to this chemotherapy with a decrease in size, yet this is a pretty bad disease in the liver. And here we decided to go to portal vein embolization. So the portal vein embolization was done in the disease part of the liver, but it failed. I mean, you can show the data here, pre-embolization, 6 weeks after portal embolization, that's what we have to wait to have a result. Basically, there was no change in the volume. You see 38% to 32%. Very difficult, no, very important, this patient is steatohepatitis. So here we were very careful with just looking at the volume. That was a patient with a high risk. So here, what we do, we have the knowledge that the ALPPS can rescue the failure of portal vein embolization. So we wanted to offer to this patient the ALPPS, and you can see that's what we did. In fact, the chemotherapy very nice, but the liver is still not very healthy. And here we decided basically to do a partition only for segment 6 and 7 in this situation, and keeping of course, the right hepatic vein. Pretty challenging operation, and for safety reason, with the knowledge, we did a partial ALPPS, meaning we went to about 2/3, and then we stopped because we were very worried going close to the hepatic vein that we may cause problems. And here you can see the X-ray, which was done at the first step. So you see here the in situ split of this, and the small part below next to the kidney, segment 6 and 7, that was left for the partition. So we had at 1 week not so much increase. We went to 49%. At that cases, we did the ITG green, which was better, 9.3, but still a bit worrisome. So we decided to wait another week, and with another week, we got more. We went to 55%, and the ITG green 4.6, and we decided to go for a second step. And to our big satisfaction, this patient did extremely well. In fact, left the hospital within 9 days after the second stage. This is the liver regenerating after the segment 6 and 7 that were left in place. And that's what we had 1 week after regeneration. We know that when we take out this deportalized or diseased liver, that's another boost, and here we have an increase to 65% and a good ICG green here in this patient. So I'll come to the conclusion from this talk here. So I think this is clear now, at least in the mind of most, that ALPPS does induce an accelerated and unmatched liver regeneration in human. It's clear that we can have a rapid removal of large or multiple liver tumors in these cases. I think the data strongly suggests that we have more chance for complete resection. Randomized controlled trial need to be done to confirm that. This is clear that we have overall probably a higher morbidity, mortality that are confirmed, but again, when we selectively look at colorectal metastasis, I'm not even sure it's true, but let's accept that still. The best indication today are colorectal liver metastasis and younger age, but we will not turn down this operation for elderly patients, but we know the risk is higher. We will do this randomized control trial, and if there is center performing that, we'll be delighted to have other centers involved in this randomized control trial. And the mechanism still is open, but there is here a boost, a combination of growth factors that enable this liver to regenerate, and this is not as was postulated by the initial group for Germany. You just transect, and there is no portal communication, which is one side and the other side. This is why the liver grows. This might also be a factor, but I do believe the factor is more on an active mechanism of regeneration. So the bottom line, who should do that? Experience center. As I heard the talk before from Mike Anderson, I enjoy one slide about innovation, be courageous, and at the end try to help our patients. Many of these patients, if we have not take this risk, will be dead, and some of them are alive and do well, and that's certainly something we want to achieve. And of course the right indication, and I will take here also again, and thanks Eduardo to give me some slide that he will present soon, but I thought it was a good way to summarize the indication, because at the end that's what it is. So here we have tumor margin close to the future remnant liver, and the pedicle is certainly a good indication. When there is contraindication for portal vein embolization, I don't think you want a case like that, do portal vein embolization, because here for sure after 2 months the patient will not be a candidate for surgery because the tumor will grow in the other side. I think if you have failure of portal vein embolization, you need to think about ALPPS, or if you don't want to do it, to refer this patient to a center that do the HALP. Unexpected tumor extension also here can be done intraoperatively in these cases. And when we need a large hypertrophy, for example, in patients with other disease liver or with small future remnant liver. So I would like to thank you here because many of us are senior surgeons here, but here the two who have done a lot of work for the registry and making that happen. This is Dr. Victoria Ardiles, who is here in the room and did a lot of work, and I would like to thank her for that. And Eric Schade from my center here, and it was in 2012 when I was visiting Argentina, where we talk about that. We were not sure where we were going with this, but I think we are going somewhat in the right directions. And here, thanks to the AHPBA last night, we have a small ALPPS group here, and we're talking about ALPPS, where we should go or not. So this is also an important part of meeting when we can meet together and discuss about that. I thank you very much for your attention.